there are quite a number of questions, and one of the ones that came across most frequently is recognizing the fact that you're not a medical doctor and you don't see patients in a clinical setting. Based on your observations and your experience with patients who have both primary orthostatic intolerance and also CFS, what management strategies have you found that can help people minimize and cope with these disabling symptoms?
Well, as you point out, you know, and as I've alluded to, we have a vast clinical experience, and I'm not giving out medical advice by suggesting the strategies that we have found useful and that many people have reported to us as being useful. One is maintaining your blood volume as best you can by drinking lots of fluids, and I know many individuals derive benefit from drinking water, eating salty foods, and maintaining their blood pressure. We generally suggest the use of compression garments if and when appropriate. Jobst makes compression garments and you know, surgical stockings and such. Many sports clothing manufacturers make spandex lycra tights and leggings, and if you one of the things, as I mentioned, that happens is you get a vertical displacement of fluid from the chest downward, and certainly if you wear compression garments, it mitigates that. It helps to alleviate some of that, and many subjects have found symptomatic relief in doing something like that. There's been a lot of interest lately in the benefit of exercise, and some of our colleagues have reported benefits from mild or moderate regular exercise, and I know it's a double-edged sword, because most subjects with chronic fatigue syndrome simply can't do any exercise, and the secondary effect, as many of you know, of doing exercise is you get that rebound excess fatigue following exercise. So what we recommend is that people start out slowly, perhaps doing a little bit of walking, doing something like a bicycle or a recumbent bicycle, so as to minimize the effect of standing up and doing things, and to start slowly and try and incorporate exercise in a slow, graded fashion. Beyond that, your physician might want to consider using some agents that act at the level of local blood vessel control, but as stated previously, I'm not licensed to make those sorts of recommendations.
I'm going to put out a poll here while we move on to another question, but there were several questions about conditions that might coexist with CFS and also with different forms of orthostatic intolerance, like migraine, let's see, Raynaud's.
Yeah. Well, I'm not sure what the relationship is with Raynaud's. Certainly we've seen a number of subjects who come in symptoms of orthostatic intolerance and or chronic fatigue in whom we've seen Raynaud's. What we typically see, what we see more often and quite regularly, is when we tilt people, their lower limbs become purple, suggesting the pooling of blood locally. So we see that. We certainly see our share of subjects with gastrointestinal complaints, very, very common, and perhaps the most common comorbidity that we see is the reporting of headaches and or migraines. These are commonly seen together, and if somebody comes into our practice and mentions any or all of these symptoms, we're seldom surprised because we see it in a large subset of our CFS patients. It's the rare CFS patient that doesn't have a lot of these associated symptoms. What they're caused by, unfortunately, we don't yet know. I guess that's all I can say to that.
Okay. How about cardiac insufficiency, heart failure as a major complication? Do you see have any evidence for the existence of those things concomitantly with CFS or orthostatic intolerance?
I don't know what the demographic of the audience is today. My guess is that they are somewhat older than our subjects. We, Dr. Stewart and I, are part of the Department of Pediatrics, and most of the subjects that get referred as primary patients to us for the evaluation of chronic fatigue or of orthostatic intolerance tend to be somewhat younger than the general public, and usually are in their late teens or early 20s. As a result of that, the incidence of cardiac insufficiency and heart problems is virtually non-existent, which is not to say that there aren't teenagers and adolescents with primary cardiac problems, but the study subjects that we're allowed to investigate cannot have any underlying cardiovascular problems. That makes them ineligible for our studies, so the subjects that we see do not have any coexisting cardiovascular abnormalities. In fact, one of the inclusionary criteria are that they have to have normal cardiovascular function. As to the incidence of cardiovascular problems in subjects with chronic fatigue, I can't speak to that.
Okay.